Good afternoon, everyone. I welcome you all to this session of Rejuvenating It All from Lid Margin to Lid Margin. You all know that the ocular surface extends from the both lid margins, including the palpebral conjunctiva, fornices, limbal stem cells, and cornea. And together they maintain the ocular surface. Any damage to this, any part of this surface may lead to ocular surface pathologies. And many times you require to do the surgical intervention to reconstruct this ocular surface. So you may come across lid margin keratinization, shallow fornix, there is stem cell loss or ocular surface disorders or even the lime burn where you require to reconstruct, refresh the ocular surface. But there is always a question when to reverse the trend, how to renew the surface, how to refresh the problems and how to rejuvenate the disease. And to this, in this session, we are going to discuss in detail with case scenario based video explanation of all this scenario, on this case scenario, and tips and tricks to overcome the surgical difficulties to reconstruct the ocular surface. So for this, we have Dr. Tuhin Chaudhary, who is going to talk about the revitalizing lids in LMK by MMG. Dr. Joyita is going to talk about the reformation of obliterated fornix. Regaining the stem cells in limbal stem cell loss will be covered by Dr. Paras Mehta. And myself, Shreya Thatte, I will cover the reconstructing ocular surface by amniotic membrane. And Gautam Parwar will talk about the recovering surface in acute lime burn. So you see there are lid margin keratinization is there, and many times there is a question how to identify this lid margin keratinization, what are the features, how to prevent the complication, and how to manage this LMK, and tips and tricks for the MMG. For this, Dr. Tuhin Chaudhary is going to talk about, who is Senior Consultant in Cataract, Cornea and Refractive Services, Disha Eye Hospital. He has done fellowship in Cornea, LVPI and University at Budapest, Hungary. He is trained in corneal lamellar surgery under Professor Massimo Bussin, Italy. And he has several publication and presentation to his credit. He is regularly conducting instruction courses as a chief and co-instructor at national and international meeting. He has performed live surgeries at different conferences. He served as a chairperson of East Zone member of Eye Bank Association of India. And he is interested in eye banking, newer techniques in corneal transplantation, ocular surface disease, and infectious keratitis. He has received many awards, including prestigious Madan Gopal Cornea orations. So I invite Dr. Tuhin Chaudhary for revitalizing lids in LMK by MMG. Dr. Tuhin.
Again? Okay. Okay, good afternoon, everybody. At the outset, my sincere thanks to Dr. Thatte for this opportunity. So I will be talking on this revitalizing the lids in lid margin keratinization by mucous membrane grafting. So I have nothing to disclose in my financial consideration. So if we look at the normal lid margin anatomy, it has a convex inner border. So both upper lid and lower lid has this convex inner border. Then there is gray line, and then comes this mammalian gland orifices, then mucocutaneous junction, and the lid eye part. So lid margin keratinization is because of loss of mucocutaneous junction barrier. That leads to epidermalization, dyskeratosis involving the mammalian gland orifices, altered lid margin microbiome, and squamous metaplasia of the marginal conjunctival epithelium. So here, this because of this this mucocutaneous junction barrier is lost. That's why this epidermalization has happened in this tarsal conjunctiva. So the commonest cause of lid margin keratinization is this chronic SJS. In these cases, histologically, lid margin keratinization is because of transition of the epithelium from the stratified squamous non-keratinized epithelium of the tarsal conjunctiva, this tarsal palpebral conjunctiva, to this stratified squamous keratinized epithelium. This is a patient who had brachytherapy locally, and here this is this non-keratinized epithelium, and it got transitioned into this keratinized epithelium, and that is the lid margin keratinization. This is a patient who had this chronic use of anti-glaucoma medications, and this is a patient who had this mucous membrane pemphigoid, and that is biopsy-proven. And this is the histological picture where this epidermalization happened in the lid margin along with this mucocutaneous junction and this palpebral conjunctiva. So this chronic SJS, here you can see that is the most common cause. So this happens in which cases? So SJS, if it is not managed in acute stage properly, then this chronic stage will happen. And AMT should be done as soon as possible in acute SJS or 10 within 1 week of the onset, preferably within 72 hours before the fibrinous inflammatory exudates gets consolidated and forms the cicatrix in the conjunctiva or form this symblepharon. This is a patient. This patient was one of my friend who is the doctor in medicine, and his teacher who has having this Steven-Johnson syndrome was admitted in Apollo Hospital 10 years ago. So this doctor patient informed me. Then I did this AMT at the bedside. So at 5th day. So because of this lid margin involved, so I did without any microscope. I did this AMT without any glue. I just put it and then put this symblepharon ring. And this is this even after 10 years also there is no lid margin keratinization. So any patient with SJS or 10 who has eyelid margin involvement in the acute phase should have AMT. Other signs that which should prompt consideration for AMT is that pseudomembranes and tarsal conjunctival or fornical defects. Because all these they will just cluster together and form the symblepharon. So when we put this AMT, so we should cover all the area, including the lid margin, palpebral conjunctiva, fornical conjunctiva, bulbar conjunctiva, and the corneal surface. So if you look at the pathogenic mechanism of cicatricial ocular surface disorders, the lid margin and lash abnormalities can cause chronic blink-related microtrauma to the ocular surface. This patient had this lid margin keratinization, and when this patient is blinking, so this rough surface will rub over the smooth surface of the cornea, and that leads to microtrauma. So that leads to incomplete blinking or closure of the eye, and there is always some interference of the Bell's phenomenon. So all these things lead to this unwanted exposure of the ocular surface. Because these patients, whenever they are blinking, they will be having some sort of pain sensation. So they will not close or they will not open the eyes. Or if it is open, then it is mid-open only. So unwanted exposure of the ocular surface leads to persistent ocular surface inflammation and subsequent corneal blindness. So what are the decisions when we go for lid margin keratinization management? So in that cases, we have to go for this grading of the lid margin keratinization, and we have to ask the patient's symptoms, and that is the most important thing. Then we have to consider this corneal damage, surface keratinization, and need for intraocular procedures. What I mean that, suppose these patients, if they have this cataract, and this patient is willing for cataract surgery, then we have to go for lid margin keratinization, that we have to treat that by doing this microsphere grafting, and wait for 3 months, and then go for cataract surgery. So for grading this is by this Mayo Pasculi et al. That grading as per the cicatrix-mediated lid margin or tarsal pathologies and corneal complications. So grade 1 is this mild, there is this sporadic lid margin keratinization. So you can see that this is sporadic and less than 1/3 of the entire length of the lid margin, and with minimal subconjunctival scar. And in these cases, the cornea is clear. So this is grade 1. Grade 2 is this moderate, when the lid margin keratinization is between 1/3 to 1/2 of the entire lid length, and then invading up to 1 millimeter of the tarsal conjunctiva, and then subconjunctival scar is that is there, and that may change the tarsal contour without any cicatricial entropion. And cornea, if it is there is haze, it is located only in the peripheral part, and there is vascularization only less than 3 clock hours. You can see that there is vascularization peripheral. So this is grade 2. Grade 3 means that continuous lid margin keratinization, like in this case. This whole lid is involved, encompassing more than one half of the entire lid length and invaded more than 1 millimeter of the tarsal conjunctiva. So this is the tarsal margin, and then it has that means invaded more than almost 3 millimeter in the tarsal conjunctiva, and prominent subconjunctival scar also that causes cicatricial entropy on. In the cornea, there may be central corneal haze or scar or extensive neovascularization with more than 3 continuous clock hours of these neovascularizations, which may reach the central cornea. So these vascularizations, if it is continuous, more than 3 clock hours and reaching to the central cornea. So this is grade 3. So treatment options for lid margin keratinization is bandage contact lens, scleral contact lens, and mucous membrane graft. So bandage, and whenever we are treating these patients, the primary goal is reduction of morbidity and prevent complications. That is the primary goal. And secondary goal is this visual rehabilitation. Whenever these patients, they will come, they will ask that whether after surgery my vision will improve or not. We have to tell the patients that if this complications are reduced, then you may get good vision, but your this morbidity, this pain, disability will be better. The word of caution is that it is advisable to avoid any surgical intervention in a patient with SJS or 10 until or unless it is absolutely necessary. Sometimes you may have some sort of problems after the surgery. So if it is really necessary, then only you go for surgery, otherwise no. However, patients with bilaterally scarred central corneas require and desire visual rehabilitation. So conservative management like that, lubrication, epilation, punctal occlusions may not be sufficient, but sometimes you have to use it. Large diameter contact lenses or special scleral lenses do protect the cornea to a certain extent. Lens fitting can be a problem in eyes with significant symblepharon, and poor compliance in these cicatricial diseases are really a problem. Prosthetic replacement of the ocular surface ecosystem, that is PROS lenses, that is FDA approved, restores visual function, supports healing, and reduces symptoms. But all these are only temporary measures. But the permanent solution is that surgical attempt to improve the surface if the underlying pathological process is controlled. So how much time I have? 12 minutes, no? Okay. So indications for MMG is that recipient eye preparation, that is that you have to first differentiate the SJS sequelae from the chronic stages of MMP. This is a patient who had MMP. You can see this pharyngeal shortening, symblepharon, all these things. Because that if you do these cases with this MMP, this will be disaster. Because these patients, these MMP patients need immunosuppressive, but SJS patients don't need it. We have to go for fluorescence staining to establish that keratopathy is due to LMK, that is lid margin keratinization. So here this is the lid margin keratinization, and we did this surface staining, and this is just touching this cornea, and then upper corneal surface is having some SPK. So this, because of this only this SPK has developed, so we have to go for this lid margin keratinization, and it is the ideal case. We have to go for Sarmas test to assess the wetness of the each eye, and should be more than 5 millimeter at 5 minutes without anesthesia. So if the patient is having good Sarmas test, good wettability, then only we go for lid margin keratinization treatment, that is by MMG. So earlier days that we used to go for this living related this conjunctival autograft or allograft to reconstruct and maintain the ocular surface a healthy conjunctiva when available is the ideal matter for grafting. But a full thickness oral mucous membrane grafting is the simplest graft to use it if the conjunctiva is not available. It is preferred over the split thickness mucosal grafts as it contracts less. Split thickness grafts, that is this very thin and it contracts. But split thickness graft is more preferable from the conservative point of view because of its lesser bulk and pinky appearance. So I am now doing this surgery, I am just showing it. So first we have to, this horizontal incision by 15 number blade is placed at the gray line, and all incisions are superficial with the intention of cleaving the epithelium without damaging the tarsus. There should not be any residual patches of normal or keratinized epithelium on the tarsal conjunctival bed. Otherwise, this graft will have some sort of, either this graft will necrose, or if there may be recurrence of this lid margin keratinization. So no patches of residual there means epithelium. And the surgery is carried out under general anesthesia with the endotracheal tube secured in one side, and so as to allow this and get the adequate exposure of the oral mucosa on the other side. So then we have to, after the defect is, that means we have to measure, and then we have to put this submucosal injection to lift the graft. So after the graft is removed, then excess fat is cleared from the stomal surface, of the graft with curved westward scissors. And then we have to suture it by using 7/0 nylon, 7/0 vehicle sutures. First, you have to put this anchor suture, and then you have to
Dr.
suture
Tuhin,
it.
can you just
That's
sum
another
up
2 minutes.
fast?
And then you just go for interlocking sutures.
Dr. Tuhin, can you just sum up
Okay,
fast?
okay, okay.
Yeah.
Just 1 minute. So then this way the lower lid also to be done. And then put this fibrin glue. So this is the appearance. And this is after 3 months, you can see this. So the beneficial effects of MMG is that decrease in conjunctival hyperemia, stabilization of the corneal changes, improvement in corneal staining, decrease in corneal vascularization, reversal of the squamous metaplastic changes. So outcomes, does MMG reduce ocular morbidity and improve vision? Yes. This is the patient who had, that means too much morbidity and vision has improved. So this patient had this keratinization, and then this patient had this new vascularizations, and this is the final picture. This is the patients at the age of 12 years, and this is after 12 years also this patient is maintaining good vision. So ideal timing of lead MMG, if surface keratinization is there, it should be done as soon as possible. Otherwise, you may have this complication like infectious keratitis. And what is the worst conditions that can happen? That you should suture it, and sometimes donor may have some sort of hematoma formations. And who can do lead MMG? Anyone, not only the oculoplastic or corneal surgeons. Beginners should at least assist few cases and do first cases under surgeon somebody's supervision. So to summarize, early aggressive intervention to stabilize the ocular surface. AMT in SJS or 10 should be performed within the first week of symptoms when indicated. All patients discharged from the hospital with a diagnosis of SJS or 10 must be followed by a qualified ophthalmologist, as up to 50% of these patients develop chronic complications of the disorder. All ophthalmologists should learn how to identify various sequelae of the SJS and should have knowledge and skills to perform MMG. And these are my acknowledgements. Thank you for your time.
Thank you, Dr. Tuhin. I think because of lack of time, we will take questions after the session. We will be available outside. So, can you just put my slides? Yeah. So we come across many times obliterated fornix, and we have questions: what are the reasons for this obliteration? What are the different grades, and how to plan the surgical strategies? What are the different material we can use to reform these obliterated fornix, and how to achieve the targeted goal? This will be covered by Dr. Joyita Das, who is senior consultant in Disha Eye Hospital, and she works as a consultant in Shankar Eye Hospital and Sadguru Netra Chikitsalaya Chitrakoot. She published many high-index journals, and she is reviewer of Orbit BMJ case reports. She is regularly conducting instruction courses, and she is recipient of many awards, including the Best Video Award in OSWB, Best Lecture Award in Confluence and International Conference, and Best Paper in Kolkata Academy of Ophthalmology. So I just invite Dr. Joyita to talk about the reformation of the obliterated fornices. Dr. Joyita.
Okay. Thank you, ma'am, for the kind introduction. I'm Dr. Joyita Das. I'm actually an oculoplasty orbit surgeon. However, I have keen interest on ocular surface because I have the privilege to work with sir like Dr. Tuhin Chaudhuri and his team. So without spending any time, I'll just start my presentation. My topic is reformation of the orbitolated fornix. So what is conjunctival fornix? Conjunctival fornix is anatomically formed by the conjunctival tissue which are starting from the limbus to the lid margin. It is mainly divided into two, upper fornix and lower fornix. Normal deep fornix plays an important role in maintaining the ocular surface health. It provides sufficient tear reservoir, which helps in smooth blinking, and it provides a full range of ocular motility. So, when the fornix is obliterated, it causes various ocular surface problems. It caused by chemical and thermal burns, mechanical trauma, some cicatricial conjunctival disorder like mucous membrane pemphigoid, Steven-Johnson syndrome, adenoviral membranous conjunctivitis, recurrent pterygium surgery, even crude evisceration and enucleation surgery also can can cause obliterated fornix. If the fornix is obliterated, it may damage the ocular surface by reduction of the tear reservoir, preventing the tear flow with spread, blink-related microtrauma from an irregular tarsal surface. Ultimately, it leads to cicatricial entropion and trichiasis. There is limitation of the Bell's phenomenon. This patient has a chances of nocturnal lag ophthalmos followed by exposure keratopathy, and there will be constant inflammation of the conjunctiva. It causes ocular motility restriction, there may be strabismus, there may be visual loss related to ptosis in severe cases. And there is inadequate socket in prosthesis in case of anophthalmic eyes. So first, to manage this condition, first we have to do the clinical assessment. The surgical decision making is very essential. For that, we have to do a thorough slit lamp examination, measurement of the fornicial depth, and grading of symblepharon. Previously, there was no previous guideline to manage this condition. Only Dr. Mondino and Brown Foster, have been described 3 different grading systems, which are primarily for the progression of MMP, mucous membrane pemphigoid. However, in 2008, Dr. Ahmed and Dr. Singh et al., they have developed a comprehensive staging and algorithm of surgical strategies for fornix reconstruction based on severity of symblepharon. This is the grading system they have used. I will tell which basically based on length of the symblepharon with an inflammatory activity. First come to the length. The grade 1 is the length of the symblepharon. That is the, if you draw a line from the limbus to the lid margin, this is the A, this is the symblepharon length. Symblepharon length in grade 1 is more than the lower lid palpebral conjunctiva. This is the example of grade 1 symblepharon. This is grade 2. Here, this length is more than or equal to palpebral conjunctiva. And grade 3 is when it is both less than palpebral conjunctiva and the tarsal plate height. This is grade 3. And grade 4 is basically keratoblepharon. That is this distance, that is the symblepharon height is more than, it is 0. And the grading of severity with the width is less than A1 is less than 1/3, 1/3 to 2/3, and 3 is more than 2/3. So if we know if we grade this symblepharon in this grading, it is easier to make a decision which surgical technique we have to use. So this is the surgical procedure to correct symblepharon. The principle of this is involving the excision of the scar tissue followed by application of a tissue substitute to cover the palpebral or the bulbar surface. This is the tissue substitute. The tissue substitute which are available or which are in practice are conjunctival autograft from the other eye, amniotic membrane, mucous membrane grafting, skin grafting, silicone sheet, and some additional procedure like we can put a conformer or a symblepharon ring, beta irradiation, which are not very useful in our very much in practice, and subconjunctival mitomycin C, which we use in very severe cases with a very severe scar and recurrent cases. So first is amniotic membrane in fornix reconstruction. How does it help? It causes this amniotic membrane has some anti-inflammatory, anti-fibrotic activity that promotes epithelialization. It supports the normal phenotype of non-goblet conjunctival epithelium in culture. This amniotic membrane maintains a normal conjunctival epithelium with goblet cell differentiation in vivo in contrast to MMG. So this is the advantage of amniotic membrane over mucous membrane grafting. This mucous membrane grafting as a tissue substitute, these are basically indicated as per Dr. Singh et al. Are grade 1 and grade 2 symblepharon. The grade I have already described. Symblepharon in anophthalmic contracted socket. However, it is not indicated alone in progressive inflammation or cicatrizing disease like active SJS, MMP, or TEN. So here is a short video of the procedure. I have borrowed it from my sister, she is also cornea specialist, Dr. Nivedita. First, subconjunctival adrenaline has been injected to reduce the bleeding. Dissection of the symblepharon started from the fornix here. You have to tag this extraocular muscle, otherwise it's very risky. Otherwise you may cut it as thinking that it may be a scar tissue. This is the scar over the corneal surface has been dissected gently. This is the superior rectus muscle. Yeah. The dissection completed over the corneal surface. Now, the recessed conjunctiva in the lower fornix has been sutured with the help of a bolster. Here I am using a reti band which are used in retinal surgery, buccal surgery as bolster here. And suture it to the skin side with another bolster. There is controversy on this result of using this fornix deepening suture in fornix formation. However, in my practice, it has seen that it always gives better result with a permanent, like better outcome in maintaining the fornix depth. And a sembliferon then amniotic membrane with tissue glue has been implanted. And finally, the sembliferon ring is placed. You can give a suture, tarsorrhaphy suture for better, this is the simple tarsorrhaphy suture. Sorry. This is the patient I have shown. This is a tuna injury patient, 4 months following tuna fall. In this case, the sembliferon release and fornix formation has been done, followed by slate and optical plique later by Dr. Tuhin Chaudhary. This is the post-keratoplasty slate and antivitrectomy picture 6 months after this fornix formation. And this is post of 2 years. Patient now see around 660 vision. She is enjoying 660 vision. So next is mucous membrane grafting. The indication of mucous membrane grafting, yeah, just 1 minute. Mucous membrane grafting are severe sembliferon after chemical and injury or firework injury. Here the advantage is it is easy to harvest with mild morbidity to the donor area. It has an ample source of donor tissue of reconstruction from the ocular surface. It contains goblet cell which may improve the tear film. So this is another case of chemical injury. Here, first the fornix, first we have tied the lead suture. Next here, we have started that after the conjunctival incision, this is the excision of the sembliferon from the upper lid. This patient is a professor in not a medical college, in general college. He's a chemistry professor, had an injury while doing our lab. So here also again, I'm doing this fornix formation suture to recess the conjunctiva and make the fornix deep. It's very important to identify those extraocular muscle in these cases. By BMM graft has been taken out from the lower lip, and it is implanted, sutured over the upper palpebral conjunctiva because this side scar was very deep and extensive. This is the part of the BMM, buccal mucous membrane, which are sutured and glued to the bulbar, upper bulbar conjunctiva. Yes, this is the last one, ma'am. And rest of the surface has been closed with a amniotic membrane, and patient is preparing for slate and this other procedure. So the take-home message is progressive scarring of the conjunctiva may lead to obliteration of the fornices and formation of sembliferon in a variety of ocular surface disorder. Effective surgical needs proper surface evaluation and grading system to reliably measure the severity, and proper planning is important. This procedure also may be combined with an additional measure to prevent re-adhesion, like you can put in conformer or fornix forming suture, sembliferon ring, or mitomycin C. Thank you.
Very nicely presented, Joyita. I think she has covered almost all aspects of reconstructing the fornix. Next, we have my slides, please. Yeah. we do come across many times the stem cell loss, and it's very difficult if you diagnose it in early stage, and then you can correct them by doing the stem cell transplants. So what are the indications, what are the contraindications? That is always the dilemma, and what are the different techniques you can adopt for the stem cell transplantation, how to take care post-operatively. So to talk about this, I call upon Dr. Paras Mehta, who is Medical Director of Samik Eye Hospital and Cornea Center, and she is Honorary Medical Director to Elmex Eye Bank, and Shri Bhaichand M. Mehta Corneal Transplant Center at Baroda. She has several publication and presentation. She has been conducting instruction courses on various corneal condition and corneal surgical procedures. She served as a president of Baroda Ophthalmic Society for the year 2008 and 9. She served as a West Zone member of Eye Bank Association of India, and her areas of interest are eye banking, new techniques of corneal transplantation, ocular surface disease. And she has very wide varieties of hobbies like photography, traveling, trekking, reading, and playing table tennis. So I call Dr. Paras Mehta a versatile person to talk about the stem cell transplantation, regaining stem cell in limbal stem cell transplantation. Thank you.
Thank you, Dr. Shreya, for that generous introduction. At the outset, I would like to thank the scientific chairperson of the AIOC and the AIOC team, and Dr. Shreya for bringing me here. So I will be talking to you about regaining stem cells and limbal stem cell loss. We all know that the cornea on the front surface of the eye provides our window to the world, and maintenance of this corneal transparency is dependent on the integrity and functionality of the outermost corneal epithelium, which itself is maintained by the limbal epithelial stem cells. If this adult stem cells population is depleted by injury or disease, the transparency of the cornea and therefore the vision is threatened. So limbal epithelial stem cell deficiency results in corneal opacification, inflammation, vascularization, and severe discomfort. The stem cells are present in all present in all self-reviewing tissues and have a unique properties. The ocular surface is made up of two distinct types of epithelia, the conjunctival epithelium and the corneal epithelium. Though it is connected to each other, the phenotypically both are very different. The stem cells of the cornea are located at the limbus. The microenvironment of the limbus is considered to be important in maintaining the stemness of these cells. They also act as a barrier to the conjunctival epithelial cells and prevent them from migrating onto the corneal surface. So in certain pathological conditions, the limbal stem cells may be destroyed partially or completely, resulting in varying degrees of stem cell deficiency. With its characteristic clinical features, these include conjunctivalization of the cornea with vascularization, appearance of goblet cells, and an irregular and unstable epithelium leading to recurrent epithelial breakdowns. As you can see here in these clinical pictures, they are all labeled. Like first slide shows that he was a welder. Because of chronic actinic damage, he developed double pterygia-like appearance, a patient with OCP and chemical injuries in the bottom line. These are the other causes, like a young patient with chronic soft contact lens wearer ended up with limbal stem cell deficiency and chronic VKC with LSCD. So these are the etiological causes. Broadly, it can be divided into congenital and acquired, and you can go through the list. In the interest of time, I will not go through this. But if we can put it into a diagram, the majority for unilateral LSCD, the majority causes chemical injury, while for and the others comprise the 20% of the injuries. The bilateral LSCD, the causes are different, but still here, VKC and chemical injuries and the chronic cicatricial diseases make the most of it. The corneal transplantation alone is ineffective in limbal stem cell deficiency, as it results in recurrent epithelial breakdowns, surface healing issues, and ultimately graft failure or sometimes graft melt. So fortunately, limbal stem cell transplant can restore normal epithelial phenotype and re-establish a stable corneal surface. In patients with LSCD, the healthy fellow eye can serve as the source of donor limbal tissue for unilateral buns, while for bilateral LSCD or limbal stem cell deficiency, when the autologous limbus tissue is not available, one can resort to donor limbal tissue, either a cadaveric or from the living related donor. So previous strategies to correct limbal epithelial stem cell failure include transplantation of limbal autografts or limbal allografts from a donor, Both have drawbacks, including the potential creation of limbal epithelial stem cell deficiency at the donor site or the requirement for long-term systemic immunosuppression in cases of allografts. So coming to techniques of limbal transplantation, also recently it is more known as limbal stem cell therapy. If you look at this algorithm, the first and foremost part of treating a limbal stem cell deficiency is controlling the inflammation of the ocular surface. That is very important to maintain the stem cells which are transplanted from the fellow eye or from the donor. So this is the most important part. Then we can divide it into partial limbal stem cell deficiency or a total. If it is partial, patient could be asymptomatic, which can be just treated with medical management, maybe occasionally with lubricants and occasionally with topical soft steroids. If the patient is symptomatic, they might require amniotic membrane transplantation or sometimes sequential conjunctival epitheliectomy, which was popularized by Professor Dua. Ipsilateral limbal translocation also can be done. For total limbal stem cell deficiency, if it is unilateral, one can do a conjunctival limbal allograft or a SLET, which is known as simple limbal epithelial transplant, or a CLET. If it is bilateral, and one can use either allogenic based limbal transplant, which could be from the donor. There are various things. We may not go into that detail, the reason being that we would be addressing more of a chemical injury here. Just briefing about the basic terminologies, like conjunctival limbal autologous transplantation is a procedure which includes obtaining 2 grafts of 2 clock hours each from limbus and the adjacent rim of conjunctiva from the patient's other healthy eye. This procedure has the longest track record and has been shown to successfully restore the corneal epithelium in approximately 75% of the cases. But drawback is it creates a limbal stem cell deficiency into the donor eye. Then came the cultivated limbal epithelial transplantation, wherein Pellegrini and all described cultivated limbal epithelial transplantation, where they took 2 by 2 millimeter piece and then they expanded it ex vivo and transplanted. It takes about 2 weeks and transplanted onto the recipient eye. Then in 2012, Sangwan et al. Described the technique of simple limbal epithelial transplantation, where a strip of donor limbal tissue from the superior limbus, similar to CLET, is obtained from the healthy eye, but instead of ex vivo expansion, it is divided into small pieces and transplanted directly onto the affected cornea for in vivo expansion over a human amniotic membrane graft. As you can see here, there were certain modifications which were popularized, like sandwich technique, where double amniotic membrane is used combined with conjunctival autograft. It was also combined with mucous membrane graft. And recently, people are describing SLET with amniotic membrane without amniotic membrane and directly applying these pieces onto the recipient bare stromal tissue. We may not go into the details of the results, but to simplify for the clinician, if there is a conjunctivalization in the peripheral part or there is a partial LSD, there is no need for SLET. You can just go ahead and do a conjunctival autograft. You can, do tarsorrhaphy along with or depending on the need of the hour. If it is conjunctival, peripheral conjunctivalization of the peripheral cornea plus central corneal superficial stromal haze, one can do a conjunctival autograft and or SLET. If there is a total limbal stem cell deficiency but not much of a central scar, maybe probably SLET is a good option with or without conjunctival autograft. This is a pictorial representation from a very recent publication from LV Prasad Eye Institute. You can see that SLET is recommended in the top row, while SLET plus conjunctival autograft is recommended in the other, and bottom 2 rows, SLET is not recommended at all. So we look at quickly clinical cases. This is a bilateral acid injury patient who had injury of different grades, developed pannus in one eye. So we ended up doing a pannus resection from the pannus resection with a conjunctival limbal autograft from the fellow eye, as you can see here, and his vision improved from 624 to 69, and a temporary tarsorrhaphy helped in stabilizing the surface. This is a video of the same procedure. As you can see here, if there is just a pannus, you don't need to do a SLET. You can just remove the pannus from the corneal surface, do a conjunctival excision there, allow the conjunctiva to fall back, remove the tenons, clear that area carefully, and then you can take a donor tissue from the same. I'll just quickly run through the clinical pictures only and apply it there. So this is harvested from the fellow eye, as you can see here. Along with that, I've taken a small limbal ledge. So it is, instead of conjunctival autograft, you can call it as CLAG, conjunctival limbal autograft. And this is put onto the recipient eye, as you can see here, and attached with a tissue glue. But you have to be very careful that you have to keep it little away. The conjunctival part should be kept about 1 millimeter or 2 away from the limbus. The reason being that you allow the corneal epithelium to cross over rather than the conjunctival epithelium to cross over the other side. So this is another case with a bilateral acid injury, responded to BCL and medical management initially, but later developed localized LSCD. As you can see here, recurrent redness episodes, and he needed a conjunctival autograft, and I did not do a slat here. You can see that he underwent a pannus resection, conjunctival autograft from the same eye, and he did very well. This is another case, 10-year-old male child with Lyme paste injury. You can see that we did a conjunctival limbal autograft in this case, and the cornea behaves very well. He had also restriction of eye movements. This is a 28-year-old male who presented with Lyme paste injury. He had undergone twice, tenonplasty and amniotic membrane elsewhere. Came with recurrent red eye, restricted eye movements. As you can see, the lid is attached to the cornea or the globe. Symblepharon with pannus with near total limbal stem cell deficiency, shortening of the fornices, and the eye was quite inflamed. After covering the inflammation, we went ahead to do a slat and a conjunctival grafts on both the sides. Almost 360-degree conjunctival grafts from the fellow eye were taken. Both the grafts were taken from the superior part, as you can see here. You can see that limbal tissue being dissected. About 2 by 2 millimeter limbal piece is dissected, and it is cut into several pieces and applied onto the recipient bed. Here you can see that the conjunctival graft is covered. It works as a barrier, so it doesn't allow the symblepharon to occur later on in the recipient eye. And then this was covered with amniotic membrane, and then you can put your slat explants onto the amniotic membrane, put in a bandage contact lens, and then a small tarsorrhaphy, temporary tarsorrhaphy kind of, which can be there for 2 weeks to 4 weeks depending on how long you want it, clinical progress. That would work very well for these cases. You can see that small pieces are made out of that limbal tissue. A very small tissue is required, and this is arranged, and tissue glue is being applied. Once it sets onto the cornea, BCL is put and the tarso is applied. This is the post-op result of the same patient. This is almost 5 years post-surgery. You can see that the cornea is looking very well, the donor as well as the recipient cornea. This is another case where we had done here we have used a variation, like, it was a donut kind of a amniotic membrane where we just allowed the central cornea to be without the amniotic membrane. We have applied the slat into a restricted area where the symblepharon was there. So you can see the results in the last picture. This was a case of total limbal stem cell deficiency. She underwent 2 amniotic membranes. She had a vitreolage, and then she ended up with 360-degree limbal stem cell deficiency. You can see we have done a slat, and the cornea looks much better. Here we did not use conjunctival autograft because she did not have symblepharon formation. This is another 45-year-old male patient who was an industrialist, ended up with the injury with a disinfectant powder almost 30 years back, and he kept on moving from one place to the other with recurrent surface breakdown and inflammation. We did a slat and CAG for this, and 2 years post-surgery, the eye has been very stabilized. So this is another clinical case. At times, we would like to do allolimbal transplantation, and that is indicated in living-related donor, cadaveric fresh donor tissue we can use. Alloslat, usually we take large clock hours of donor tissue, or sometimes one can take a pinch biopsy from the fresh donor limbus. Since it is allogenic tissue, it needs long-term systemic immunosuppression. For bilaterally injured or damaged cases, this can work as a boon to visually rehabilitate these eyes, especially chronic VKC and chemical injury patients. So to summarize, one can customize the treatment based on clinical condition. Techniques of limbal transplantation have evolved greatly over last decade, and SLAT combines the advantages of both conjunctival limbal autograft and CLAT, and is a simple, inexpensive, single-stage technique with anatomical and functional success rates equal to or higher as compared to conjunctival limbal autograft or CLAT. The cost is significantly lower with SLAT as compared to CLAT. In the setting of bilateral limbal stem cell deficiency, allogenic SLAT is a potential option, but it will require long-term systemic immunosuppression. However, Eloslet from cadaveric donor is being used to stabilize the ocular surface quickly in severe bilateral acute chemical injury recently with good outcomes. So to summarize, the key points for successful outcomes in these cases would be prior control of inflammation, counseling for the outcomes, and need for long-term follow-up of these cases for good success. Thank you for your kind attention, sorry.
Thank you, Paras, for excellent presentation and explaining how to regain the corneas in stem cell loss. Thank you.
Can I have the Dr. Shreya's slide? Introduction slide. The next speaker is Dr. Shreya Thatte, a versatile surgeon, a very senior practitioner and teacher at Indore. She would be talking to us on reconstructing ocular surface by amniotic membranes. Dr. Shreya is a professor and head of the Department of Ophthalmology at SAMC and PG Institute Indore. She is a reviewer in many national and international journals, has several publications in Indian and international journals as well, has been conducting instruction courses at state, national and international academic meetings as today. She served as divisional and state society with prestigious posts of president, secretary and chairperson scientific committee. She received many awards at various divisional, state and national conferences, including few are best presentations by lady ophthalmologist, gold medal in Cornea and best teacher award. Her areas of interest are intense work in the field of ocular surface disorders, dry eyes and keratoplasty. And no wonder she is conducting an instruction course here on the same subject. I welcome you, Dr. Shreya, and the podium is yours.
Thank you, Paras. So I'm going to talk about the reconstructing ocular surface with amniotic membrane. I do not have any financial disclose. We may come across these various types of ocular surface disorders, and reasons are infection, inflammation, scarring, degeneration, loss of stem cell, thinning, melt and loss of stroma. And solution for these all different types of ocular surface disorders are varieties of grafts like conjunctival, corneal, scleral, stem cell and amniotic membrane graft. They provide tectonic support, but everyone can't stop the ongoing infection and inflammation. So we require something which can stop this ongoing infection and inflammation, and amniotic membrane can does that by stimulating the reepithelization. It has very good anti-cicatricial activity. It prevents the neovascularization. It has anti-inflammatory quality, and best part is there is no immunological rejection. And it has high tensile strength, so can be used for the larger surface area. And this work was published as an amniotic membrane transplantation and option for ocular surface disorders. The clinical uses of amniotic membrane can be in acute condition and chronic condition. Acute condition, Dr. Gautam Parmar is going to talk about in acute condition, AMT in chemical burns, so I am not going to present. This work was also published. Then in chronic conditions, it can work as to restore the corneal integrity in various types of corneal disorders, and we will see one by one. So this was cases with the spheroidal or band-shaped keratopathy, where you just scrap this pathology and put the amniotic membrane, and you can get the definite decrease in the corneal haze and improvement in the vision. So this work was also published. In cases with the refractive infectious keratitis, where corneal ulcer is not responding to the medical therapy, here also you can put the amniotic membrane, and because of its property, it helps in healing of such type of refractive corneal ulcers. The technique is very simple. You just take out the infected necrotic material, deepithelize the things, just put the amniotic membrane. Depending on the thinning of the cornea, you can put single layer or multiple layer. And you can see the results. There is absorption of the amniotic membrane and it turns into the corneal opacity. Similar way in cases with the corneal thinning, the technique is same, but at the place where there is thin cornea, you just put the multi-layer of amniotic membrane, fill that gap and suture it, or even you can put the glue over this, and above this multi-layer of the amniotic membrane you can put a single sheet of the amniotic membrane, and you can see the good achievement in the good healing in the form of leukomatous corneal opacity. So these varieties of infectious keratitis was also published in different types of paper. This amniotic membrane also helps in the perforation, whether it is small perforation, moderate or severe type of perforation. Again, the technique is same. You just scrape out all the slough necrotic material and you can put multi-layer amniotic membrane. You may glue it or you can put the sutures over it. It is very simple, but you can see in this picture, side pictures, there is a small perforation, membrane is in the place, and after healing you can achieve a good thickness of the cornea. So these are various cases of the perforation where amniotic membrane was used. So in this case, after complete healing, only cataract is there. If you operate the cataract in such cases, the patient can regain the vision. Few more cases here also you can see there is good achievement of the corneal thickness also. So with amniotic membrane, it's not only the healing, but you can get the thickness. In big perforation where you are not getting the donor corneal graft and you can't let this patient like this, so you just put the amniotic membrane, it will definitely reduce the inflammation but cannot give the tectonic support, and later on when you get the donor cornea you can do the keratoplasty. So this various size of corneal perforations were also published in different types of the journals. In PUK also this is very useful. You can go for the lamellar keratoplasty, but if you are not having the donor cornea, you can just do the proper dissection, take out the fibrosis and necrotic material, but in perforation or such type of thing, you take care that over the perforation, just remove this necrotic material in the end, so that you don't lose the anterior chamber depth, and then put the roll of the amniotic membrane, and you can see on the pictures there is good healing of the this PUK. This was also published. So slit I am not going to talk about. This was patient with chemical burn, and this was covered very well with the Paris. Few more cases with the stem cell slit in stem cell deficiencies. So amniotic membrane can be used as a ocular surface reconstruction in various types of ocular surface disorder. This was case in pterygium also. In recurrent pterygium you can use amniotic membrane, or even for the larger pterygium, I do the mini ipsilateral slit, where you take out the pterygium and from the same eye you take the small lenticles of the stem cells, and then you can put the amniotic membrane, and over the amniotic membrane you can put this small lenticles of the stem cell over it, just like similar to the slit what we are doing, but you are doing it for the smaller. And in pterygium also, recurrent pterygium, you just take the pterygium out, put the amniotic membrane with the glue, and above that you can put the conjunctival limbal autograft, so that it double protection is there, so the chances of recurrence are very less in such cases. Symblepharon release or Joyita is already covered, so I am not going to cover, but in blind eyes also, where there is shortening of the fornix, symblepharon is there. This amniotic membrane can help you to reconstruct the fornix and can give the good prosthesis. So this work in blind patients also was published. In the end, I will just tell you one case with post small incision cataract surgery. There was surgically induced necrotizing scleritis. Sclera was very thin, and here also I put the roll of amniotic membrane, and this was healed completely. So with the help of amniotic membrane, you can treat the various types of ocular surface disorders of various etiology. Thank you. Anybody wants to any questions? I think we will take it in the end.
That was fantastic talk, Dr. Shreya. and you have covered almost all the aspects which comprehensive ophthalmologist would want to understand as far as amniotic membrane usage is concerned. Thank you.
Let him talk first.
Can we take question?
No, let him talk first.
Let him finish this and then we get to. So, many times we come across the chemical burn and why there is an emergency about the chemical burns, what is the immediate line of treatment, how to minimize the complications, what are the medical management options, what are the surgical management options, and what is the tip and trick to achieve the optimum results. So this is going to cover by Dr. Gautam Parmar, who is head of the cornea and refractive surgery at Sadguru Netra Chikitsalaya Chitrakoot. His expertise in cataract, cornea and refractive surgeries. He has several publications in Indian and international journal, including the stenciling based prick and print technique. And he has conducting instruction courses regularly in various academic meetings. He has received many awards. So in my session, all our awardees, everyone got award from various podium. And he got award as a Young Achiever Award in 2017 by Indian Society of Cornea and Keratorefractive Surgeon. And Best Video Award in Stenciling in Ophthalmology in Jam Session, Keracon 17. So I call Dr. Gautam Parmar to talk about the recovering surface in acute chemical burn. Thank you.
Thank you so much, ma'am, for generous introduction. And at the outset, I would like to thank Shreya, ma'am, for giving me the opportunity. I'll be speaking on the recovering the surfaces, ocular surface in lime burn. So as we know that acute lime burn is an emergency and we have to do quick actions, otherwise we may land up in the lot of sequelae. So my previous speaker already mentioned, so I'm not going into the detail. There are a lot of sequelae which can happen after acute chemical injury. So mostly we have three distinct etiological group we come across. Like the kids are most commonly affected by tuna packets in our area, and the young adults, they are most commonly affected of acute lime injury while using carbide gun to scare the animals to protect their crops. And the third, which is little less common and which is young ladies come because of some accidental exposure while whitewash. So the management is very crucial. Like first we have to do emergency management. Then we take a proper history to get an idea of the nature of chemical agent and the severity of it. And then we assess it properly and put a proper classification, like Dua's classification is very famous for this. And then we prognosticate the case and do counseling according, because these cases needs multiple surgeries and frequent visits to the clinic. So we have to counsel them well. And then we either manage medically or surgically depending upon the severity. So the purpose of management is get rid of all the lime which is exposed, and then we should promote the epithelialization. At the same time, we should reduce the inflammation to prevent further damage to the ocular surface, and the reduce long-term sequelae like symbol front formation and fornical shortening and the glaucoma, which may happen eventually. So coming to the emergency management, so the main theme is that we should irrigate the surface copiously with the either tap water or diaphoterine. Diaphoterine is a preferable product because it maintains better osmolarity and better maintains pH, though I have no financial interest in this. And we normalize the pH of the surface and wash out all the lime. It should be done as soon as possible. Someone can use this Morgan lens for the uncooperative patient. It can be fitted in the eye and we can connect it with the irrigation solution and it irrigates the ocular surface. So it is very effective for uncooperative patients. Coming to the medical management, the mainstay is lubrication. We have to lubricate well. Then steroids should be given to reduce the inflammation. Vitamin C to promote epithelialization, fastens the healing process. Doxycycline is again MMP inhibitor, reduce the inflammation, and anti-glaucoma medication if the glaucoma happens. So coming to the surgical management, the removal of the lime, and we should cover all the surfaces with the amniotic membrane as ma'am already said, and alloslate is already covered. And one thing is tenoplasty we can do if there is chances of severe anterior segment ischemia and chances of phthisis of the eye. So the purpose of the line removal with MT is to reduce the inflammation and promote epithelialization, reduce symblepharon formation, and while chronic, we manage the chronic Lyme injury cases, we get a better plane and better pannus dissection once if you put the amniotic membrane. So here I am showing a video that you can see the superior fornix is studded with Lyme, and we should remove all the Lyme. Here I am scraping it using a 15 number blade, retracting the lid and removal of all the limes from the superior fornixes as well as inferior fornixes. The corneal Lyme can be removed, which is very superficial, and then limited resection of the conjunctiva, because too much dissection will disturb the surface, and then I wash the whole surface to remove all the bits of Lyme, and then the raw surface is covered with the amniotic membrane. This will reduce the inflammation as well as protect the symblepharon formation because it covers the raw surface. So I am using fibrin glue here to cover the whole surface. The extra part should be cut, and this is peripheral most part, which is stuck, and then I put a continuous suture also because it's a kid, so better to put a suture to give a extra protection to retain the amniotic membrane. And alloslate is already popularized, can be used for the acute Lyme burn. Mostly it is cadaveric. We prefer cadaveric from the young donor within 24 hours of the harvesting. It has advantages in the severe grade of the chemical injury over the amniotic membrane alone. It promotes the faster epithelialization and less symblepharon formation. And the most important thing is, though it is alloslate, but we need not to give immunosuppression because we never bother about the rejection of these grafts. They're just to promote the epithelialization. One thing is tenoplasty we can do, the tenon's advancement also called. So this is, the purpose is to increase the vascularity to the limbus, and it provides vascular pedicle to the ischemic sclera. So basically it's a globe salvaging. Though there are a lot of symblepharon formation and the conjunctivalization of the epithelium of the surface, but it is just to salvage the globe, otherwise the eye may land up in the phthisis. So here I am going to present a case. It's a, as you can see, there is 360-degree limbal ischemia. It's a young 13-year-old male after exposure to the Lyme presented to us, and so we decided to do limbal advancement surgery here, and here is the video. Here I am dissecting the tenons from the overlying conjunctiva, and the necrotic sclera, ischemic sclera should be excised, and you can see that is small linear perforation is there. So I washed the exudates from it, dissecting the tenons from the conjunctiva, and then surface, then sclera, and then again dissecting it from the overlying conjunctiva to make it free. And then I secured, since the perforation is just a linear perforation, so I secured with suture only, and I secured the whole tenons tissue to the limbus, as well as some bit I secured to the to cornea also with a 10 nylon suture, because my goal is just to vascularize the surface, nothing else. Though I know that it may end up in the severe symblepharon formation and conjunctivalization of the surface, but since the purpose is to promote vascularization, and then I used an amniotic membrane over it to give a protection and anti-inflammatory effect of the surface with the help of amniotic membrane. The extra amniotic membrane was excised, and it is again used fibrin glue to stuck it well, and then secured with the sutures also. So this was the result. You can see the first post-op day picture. It is a swollen amniotic membrane. Then 1 month follow-up, there was a central epithelial defect, but the surface was vascularized very well. And in the third picture is the 6-month follow-up, and there is a formation of some granuloma, but the surface is vascularized very well, though there are a lot of symblepharon and ankyloblepharon formation, but I am happy because which ultimately solves the globe. Now, sometimes in acute lime burn, we have a lot of intraestomal lime cases also, and these are very difficult to pick them up. So, and we know that the lime has a peculiar property that it is due to membrane saponification, it goes deeper and deeper into the layers of the cornea. So what we do, we should not bother about the intraestomal lime, we should let it consolidated in the posterior layers of the cornea. And I just want to share one such case where the lime was settled to the posterior corneal lamella. It's a 21-year-old male, post-carbide gun injury. The vision was PL, positive with PR, inaccurate, and we can go for penetrating keratoplasty also, but as we know that chemical injury is a high risk for penetrating keratoplasty, and you can see in the AIOC that whole the lime is settled in the posterior lamella only. So we apply here an unique approach that is DLEC. DLEC is the deep anterior lamellar endothelial keratoplasty, deep lamellar endothelial keratoplasty, where I resected out, first I split the cornea into 2 halves using this crescent knife as well as this blunt dissector. Since as you can see, the clarity of the instrument is here, means the anterior lamella is free of lime. And then I bisected this posterior lamella and resected out this posterior lamella using curved Vannas scissor from these 2 halves of the and you can see the posterior lamella containing almost white, containing all the lime particle, while the anterior lamella is relatively clear. And then I dissected the donor for the posterior endothelial keratoplasty. We use this anterior lamella for larger therapeutic graft also, so we always preserve this anterior lamella also, and resected out, shaped the posterior lamella and then inserted using this cystitome in place of the posterior lamellar defect, and then put air, and then I reposit the lamella and secure the wound with the continuous suture. And this is the early postoperative picture. You can see there was some clarity with on AIOC. There is very well opposed posterior lamellar endothelial graft, and this is 9 months postoperative, and the vision was retained to 660 with clear visual axis, and there may be some residual lime in the periphery, but we should not bother about that because we made the visual axis very clear, and you can see the graft is also well opposed here. So my take-home message is acute lime burn is an emergency surgery, emergency management, and we should assess it properly and then prognosticate. We get rid all the limes and amniotic membrane to protect the raw surface with or without yellow slate to promote epithelialization and reduce inflammation and symblepharon formation. Tenoplasty is also to handle the anterior segment ischemia, is very useful, and intraestomal lime should be dealt later. And one message I want to convey, that prevention is always better than cure. So we should ban all these lime pouches and the use of these carbide guns. So thank you so much for your patient listening.
Thank you, Dr. Gautam, for presenting wonderful cases, different varieties of lime burn and different techniques. And here we end this session, but we have amongst us Dr. Kyonjin Cho from Korea, and he's going to talk about Fuchs endothelial corneal dystrophy, pathophysiology, diagnosis and treatment, the keynote address. Dr. Kyonjin Cho.
Hello everyone, I'm Kyongjin Cho from Dangung University Hospital in South Korea. I want to express my gratitude and honor for being invited to this wonderful AIOC. 53-year-old woman visited the hospital due to a gradual decrease in vision over the past year. The symptom wasn't in the morning. On the little illumination and the slit lamp images, we can see the small dot on the endocellular cell layer. You may know likely aware the diagnosis for this patient and the treatment. thesis content of this presentation, let me begin by discussing Fuchs dystrophy. Fuchs endothelial corneal dystrophy is the most common primary corneal endothelial dystrophy and the leading indication for corneal transplantation worldwide. Fuchs is characterized by a progressive decline in the number and function of corneal endothelial cell and the formation of guttae. Guttae are most prominently observed in the little illumination mode. The grading of guttae. The first sign is the guttae in the central corneal endothelium. In the next stage, guttae extend peripherally and merge. In advanced stage, the cornea exhibit component guttae with diameters exceeding 5 millimeter, or there may be visible stroma or an epithelial edema. Fuchs dystrophy also have stages. In stage 1, small central guttae, it noteworthy that while some patients develop guttae at this stage, however, they may not progress to later stage in some patients. Fuchs dystrophy can be categorized early onset and late onset. Late onset is more prevalent, typically observed in the first to fifth decade, with a higher incidence in the female. The major treatment modality is the corneal transplantation, especially DMEC or TSEC. Moreover, in relatively early cases, treatment with the TSO is occasionally considered, although its application is somewhat limited. TSO is a viable treatment option for patients who have localized endothelial disease within the central 5 millimeter. DMEC surgery can be divided based on tissue orientation, tissue insertion technique, and tissue preparation method. Based on the analysis of the result from the Wilmer Eye Institute in the United States, when I was a clinical fellow there, it was found that the outcomes of DMEC surgery in Fuchs is very nice. Many Fuchs patients also have cataract because most of them are at the old age. This 68-year-old female patient shows the corneal swelling and the cataract, diagnosed with Fuchs and moderate cataract. The tomography of left eye shows the severe corneal swelling. We applied the Parco and the TSEC. What is the choice of the IOL? Hydrophilic versus hydrophobic, MA target versus myopic target. We selected the hydrophobic IOL and minus 0.9 of the target. Cornea become very clear and reflection close to MA after surgery. In Fuchs patient, why to aim for a myopic target? There are keratometric change only on the posterior surface, no anterior surface. So total corneal reflection change to hyperopic shift after cataract surgery. So we need a myopic target. In Fuchs patient, if they have cataract and cataract, we need to check what is the main cause of vision problem. However, it is difficult to know whether patient have subclinical corneal edema or not. We can get information about the subclinical corneal edema using 3 kinds of features from the pentacam images. Those are nasal displacement of sinister photo of the cornea, irregular isopark, and posterior surface depression. Fuchs patient shows these all 3 kinds of the features. However, A patient do not show any subclinical signs in the pentacam images. So we planned the Parco only for A patient. However, we planned the Parco and the TMEC for the B patient. We reviewed the medical record at 97 Parco and TMEC cases treated from the Wilmer Eye Institute. Our IOL calculator shows the hyperopic error close to 1 diameter, plus the 1 diameter in Barrett and Hopper Q West. So this is why we need the myopic target. If they have less than 1 tomographic picture of the corneal subclinical edema, hyperopic shift was minimal after surgery. However, if more than 2 hyperopic shift, if 2 hyperopic shift close to 1 diameter. This patient is the Fuchs patient I showed the beginning slides who have Fuchs and cataract, very advanced endocellular dystrophy. Betacam shows the corneal swelling. We selected the hydrophobic IOL and minus 0.71 myopic target. This is the surgery video. In this case, I did the PACO. And did a D6 surgery by a pull-through technique. So when I do the DMAC or D6 surgery, I use these kinds of some infusion forceps. So that will be the interest in the later this presentation. So I successfully did the PACO and the D6 surgery here. To use a pull-through technique in D6 or DMAC, the infusion forceps is used in my surgery. I would like to introduce shortly. Prior to the surgery, connect the forceps to the infusion slips with a BSS filled syringe like this. Endo in DMAC tissue unfolds as anterior chamber gets looms as BSS go through infusion forceps. This is the surgery using the forceps. The preloaded endo in tissue is gently pulled into the anterior chamber. Subsequently, by injecting the BSS, and the tissues unfold automatically. Research on the pull-through DMAC surgery using preloaded endo in tissue and this forceps in the Fuchs patient has demonstrated promising outcomes. This is the other case that we now want to introduce. We used the infusion forceps for complicated DMAC of previous vitrectomized. In vitrectomized cases, like this case, achieving a shallow anterior chamber can be challenging, making DMAC difficult. However, the use of this pull-through technique with the endo in tissue and the infusion forceps enables the successful execution of the DMAC surgery. This is the procedure of the surgery. First, we need inferior iridotomy. Like this, I used a micro retinal scissor, and this is main incision, and marking for around 7 or 8 millimeter, and this is the decimeter-lessis. Remove the viscoelastics and check the endo in tissue. This is not endo out, endo in check, and endo in tissue. So pull through into the anterior chamber. This patient have already the deep anterior chamber, so the tissue is unfolds automatically. And then put into the bubble, I guess, and centering the tissue like this. Very nice result of the surgery. This is summary. First signs are occurring mostly in the first fifth decade of life as glutae in the central cornea endothelium. Sham plug tomography is useful for discriminating the subclinical edema. DSO is a viable treatment option for patients who have localized endothelial disease within the centrum 5 millimeter of the cornea and have a clear peripheral endothelial layer. In terms of IOL selection, hydrophobic IOL are preferred if the future DMAC is anticipated because we need gas or air. A refractive target of the minus 0.75 to minus 1.0 diopter per combined surgery of PACO and DMAC surgery. Thank you so much.
Thank you, Dr. Shaw, for showing such a wonderful videos of managing Fuchs dystrophy. Thank you so much. And here we end this session and we hand over stage to next session of moderator. Thank you.